I believe we can now officially say good afternoon. This is an exciting moment today. But thank you all for being here today, and most importantly, thank you to Sarah. Thank you to Celeste for helping out our entire medical faculty with a session on opioids. There are, as many of you probably have read, and thus the reason you're here, a CME requirement for those of us who practice in Maryland. And so while they have been a little bit cryptic about the needs for those, there's no indication that they are not asking everyone to have that 1-hour CME opioid requirement. So you need to have it by the end of this month, and so that was the rush part of it. And so thank you again to both you all, and to anesthesia, and also to the med ed group, especially Dr. Odolini for helping us out, and for Rachel for getting this all figured out. So I'm going to turn it over to Sarah. Thank you very much again for doing this, and off we go.
So I'm Sarah Reece. I'm one of the pediatric acute pain management physicians here, along with Celeste Martin, one of my colleagues. And we're here to talk to you about pediatric pain management with kind of a focus on opioids. We have no disclosures to tell you about. We wish we did. That would be awesome, but no, not really. We do talk about medications in a way that they're generally prescribed. I don't know that we're really going out of FDA guidelines with any of our discussions here, but we're not going to be focusing on anything crazy or not FDA approved for our populations. What we're going to do is kind of the outline of stuff is I can't start telling you about pain management without going through some definitions and sort of an overview of how we look at things. And then we're going to jump into some case discussions. I'm going to talk about abdominal pain, our post-op posterior spinal fusion patient for comparison and a discussion of lots of opioids. And then Dr. Martin's going to come up and talk about PCA use, and then additionally the setting of a narcotic overdose. What are we looking for? Our objectives here, number one, we're going to review the commonly used non-opioid analgesics, because I feel like we have a lot we can be doing with those. We can be dosing them better, giving them in a better way to provide baseline analgesia. So I can't talk about opioids without talking about those. And then we want to hit on specific opioids, their indications with special populations or in special circumstances, and then look at how metabolism of these different opioids may affect our decisions to choose them, or help with our evaluation when something doesn't seem to be working. We decided we have 4 main pain pearls we wanted to let you know about. So this, you can read this, remember it, and you can leave now. This is basically what we want you to walk away with. But one thing we see very frequently when we're consulted or when we're writing orders for patients is we really want to have an around-the-clock medication given for patients. I would say if you're ever thinking about using an opioid for a patient, make sure you have them on around-the-clock something first, whether that's an NSAID or whether that's Tylenol. I recently had a kid I took care of, just a brief surgical procedure from an inpatient. He had 4 different PRN medications: ibuprofen, acetaminophen, oxycodone, and morphine. I was bewildered. I wouldn't even know if I was a nurse what to give the kid. If I was a parent, I wouldn't know what to ask, but he had nothing around the clock. And that's kind of a poor way to approach pain management, just based on asking for medication, waiting for the nurse to give it, giving it, waiting for a level to come up. So I would advocate for definitely using an around-the-clock approach with most of your pain medications. I have to talk about codeine, because this has been sort of a practice change I'm seeing now, where people are not using it anymore, which is great. And I'm going to go through some of the reasons why we shouldn't be using codeine as an analgesic for kids. And then along those same lines, codeine is almost always given with Tylenol, which very much limits your ability to optimize Tylenol dosing and optimize your opioids. So we also advocate for not using combination products of acetaminophen with an opioid, and we'll go through a little bit more of that. And then also, we want to tell you, please call us if you have questions. Something doesn't make sense with a patient, you're starting to escalate and you don't know what to do. You have a brief question about a patient, we're happy to kind of do 30-second curbside consult guidance over the phone. We're happy to see patients too when needed, so give us a holler. Our acute pain management system here at Children's is run by 6 of us who are peds anesthesiologists. We often have a pediatric anesthesia fellow with us, but we often don't, so we're just kind of flying solo. Our consult pager is right here, or the iPhone is right there, but feel free to give us a call. We're here to help you with your inpatient service. Our outpatient pain medicine care complex is headed up by Dr. Alexander, one of our colleagues. The other practitioners there right now are Dr. Rabin, Dr. Lockheed, Liz Bettini, and then we have two pain psychologists, Dr. Fletcher and Dr. Gray, who I've not met but is brand new. This is my favorite definition of pain. I can't find anything better. It is the one that the IASP came up with in 1979. They still stand by it. I think I have the reference at the end if you wanted to look at it. But what I like about this definition of pain is that it's acknowledging the emotional experience that we see with pain. And we see with kids that emotional distress can be the primary problem that we're dealing with. So this is a really nice definition, and I like to use that when we're talking. Brief review, a lot of this that I'm going to go over is review, should be review, but I feel like it's stuff we talk about a lot, so let's get it in here. When we're looking at pain, we talk about somatic versus visceral pain. These are the kinds of pain problems that we treat with our NSAIDs, with acetaminophen, with our opioids when they're needed. Referred pain we see a lot of in our post-op patients after positioning for surgeries, after insufflation with gas or laparoscopic procedures. And that is, in the adult population, you see this with cardiac etiologies, but it's something we deal with and have to do a lot of explaining to with families when patients have had laparoscopic procedures. Neuropathic pain is a whole other beast that we're not really going to get into today with its own set of medications that we use to treat that, mostly not opioids. But this is pain that starts in a nerve itself, and it just keeps going without ongoing disease or ongoing trauma to that nerve. So you can have centrally generated neuropathic pain, and you can have peripherally generated neuropathic pain. We seem to see a lot of the chemotherapy-induced neuropathies here, very, very challenging to treat. So certainly if you're worried about that with a patient, call us right away. We're happy to help start some early things to get that going. Or if you suspect neuropathic pain in a patient, that's something we definitely want to know about on the acute inpatient pain service, because we can start some medications early on to try to prevent progression for that. Acute versus chronic pain. I like these definitions. This is from a really nice textbook of pediatric pain that we like. It comes from Britain, but we still like it. But what I like about this is the idea that it gives us this definition for chronic pain. Pain that is really without apparent biological value. It's not alerting you to tumor progression, to nerve entrapment. It's that pain is still there at least 3 months after it started, and it's not helpful. It is not related to tissue damage that it should be still causing pain. So again, we tend to, when we talk about chronic pain, have sort of a 3-month timeline that we're looking at, which is difficult because a lot of times we have patients presenting after 2 weeks, 3 weeks of pain, and you sense that this is sort of a pain syndrome, not necessarily a pathological disease process that's going, but it's hard for us to give them a good diagnosis until they have met sort of that timeline criteria. I have to throw this in here because we get asked about this a lot. When the DSM-5 was revised, I guess last year or the year before, they really kind of revamped their definitions in terms of substance use. Previously, they had talked about dependence and addiction, and you'll find we all still use those terms a lot, but now they've lumped that all into one kind of continuum talking about substance use disorder. I would defer to some of our psychiatry colleagues sometimes in terms of making this diagnosis, but certainly we all deal with kids where we worry that this is becoming an issue. Unfortunately, none of us here on our pain team actually have any special training in addiction medicine, and this specialty field really has a dearth of pediatric practitioners. If you do any searching for a pediatric specialist, someone that actually has training, a lot of expertise in dealing with it, they are few and far between. I think there may be someone at Hopkins who deals with adolescents. Some inpatient chronic pain rehab programs can incorporate some of this, but for the kids that are developing a substance use disorder related to opioids or related to something else, it's really unfortunately not our area of expertise, but we can certainly kind of help guide how to go from there and who else to help refer to. So I'm jumping into assessing pain, and I don't know if anyone else's kids like this movie as much as my kids do, but Baymax has a fabulous pain scale. I don't think it's been validated, but I would love to use it here. He's an inflatable nurse that just pops up and asks kids how their pain is, and then gives them either a lollipop or a Band-Aid. He doesn't give narcotics, I don't think, but that would be even better. So anyway, I really like this. I need a t-shirt when I'm on pain service. I talked about this a little bit because I looked into this about a year ago, wondering where this idea of pain as a fifth vital sign actually came from. It's a weird thing. I think a lot of people look at this kind of with some resentment. We talk about our vital signs being heart rate, blood pressure, temperature, respiration, things that we can measure, and then we have pain, which is totally subjective. But this is a JCAHO mandate, and we're obligated to treat it with the same gravity that we do our vital signs. And part of this came from an American Pain Society program that was in the 90s. I think this was an anesthesiologist, pain doctor, who made this bold statement that we need to treat this with the same zeal as we do our other vital signs. And then someone actually listened to him and decided that, yes, we do need to treat it that way. The VA system was the first system to actually embrace this and make it kind of a mandate for them. Then JCAHO started in the early 2000s to mandate this as a vital sign that we need to pay attention to and to treat. I looked long and hard looking for some studies of the relevance of this idea of treating pain with, a number scale, calling it a vital sign. I could not find anything saying that our pain management has been more effective, more efficient, better patient satisfaction since we started doing this. But the one thing that's really scary is if you look at number of opioid prescriptions dispensed, it was already starting to go up in the late 90s, but it really skyrocketed after that. Luckily, by 2010, and you can see kind of the pinnacle, it's starting to come back down. But as a kind of an unintended consequence of saying that pain is a vital sign and then treating it very aggressively with the opioid prescriptions, it skyrocketed. And I think Dr. Martin is going to go a little bit into kind of why that's a big problem. But luckily, we're sort of, I think, on a downswing now. Nonetheless, we're still stuck using a pain score to treat patients. And it kind of makes sense, but it's very, very challenging. I had a 4-month-old I was consulted on recently, and the dad just point blank asked me, how can you tell when my kid's in pain? And, it was hard. The kid had been in the hospital almost his whole life, so I couldn't do that. Well, you know your child best, because I don't know that anyone knew how this child reacted best to anything. But for neonates and infants in particular, it's tricky. We have a couple of scales used a lot. The NIPS scale we don't use here. What's a little difficult using this one when you're comparing it to our other scales is it's not on a 0 to 10 scale. So for most infants here at Children's, I think in our NICU, we still use the FLAC scale. And this is pretty consistent. You'll use this also for kids that are a little bit older, up to maybe about 3 or so. Our sort of default scale for the preschool to early elementary school kids is our FACES scale. This is the one down at the bottom here with the pictures of the little guys that I feel should be replaced with Baymax. I think we have recently here gone to a slightly different rendition. When I was in the patient room the other day, I thought it looked a little different, but it's the same basic thing. We're going from 0 to 10 and trying to come up with a number that we can chase and we can treat. Kids that are young can tell you when they have pain, but they can't really describe it very well, as you've all seen. You're trying to ask like a 4-year-old about neuropathic pain, very, very difficult. Kids older than 8 generally are fine using visual analog scale or just going from a kind of a obscure 0 to 10 pain. Most of them can do an okay job with that. So the problem here is if we're using our pain scores to drive our prescribing practices, and then what are we giving kids, it gets really confusing. Currently in Cerner, this entire list here are possible ways for you to order a PRN pain medication. So if you want to have 3 or 4 different PRN pain medications, it gets pretty tricky. What are you going to call your pain score? If you have a savvy teenager who realizes he can get dilaudid, his pain score is 6, but you're going to give him Tylenol if his pain score is a 4, he's going to quickly understand that and ask for specific medications that they need. But this just kind of illustrates how difficult it can be to really use our PRN dosing and have that correlate with scores. I would argue pain score of 5 to me is me crying. That's really, really high, but you notice a lot of our scores, and for a lot of the stuff we're giving, we want a kid to have a pain score of 6, which to me is very, very high. But again, this is an individual choice by the kid, and they are making this score up for what fits their reference. In general, the areas of pediatric pain control, these were kind of identified almost 15 years ago in a really nice paper put out by the AAP and the APS, which is American Pain Society in 2001. They have not actually updated this yet. They have a new one out for infants and neonates, and one for treating anxiety and things related to emergency situations in older kids, but they haven't actually revamped this. I think it's still really relevant, and it's a nice article if you're looking for sort of a good review article. From our perspective, we love to take a multimodal pain approach. Medications are what we're here to talk about today, so that's what we're going to stick with. But from our acute pain service standpoint, we love to do regional anesthesia, always endorse non-pharmacological techniques and things like that as well. So jumping in, for case number 1, this is a composite patient that we have all seen multiple times. So a 12-year-old kiddo comes in. She has a 2-week history of abdominal pain. It's crampy, it's sharp. She can't really describe it very well. She's not vomited, but she feels a little nauseated. She's taken Tylenol, she's taken ibuprofen. Nothing seems to help. Review of systems is all pretty much negative. In the ED, her exam is pretty benign, but she is very, very distressed and crying. The initial lab work you do is normal. Ultrasound is fine. She doesn't have an ovarian torsion. She doesn't have an appendectomy brewing for her in the future. When she comes in, she tells you her pain score is 7 to 8. ED feels bad. They're like, we don't know what's going on. We need to give her something. They give her some morphine. And for about a 50-kilo kid, 3 milligrams of morphine works pretty well. She feels pretty good. Her pain score drops to 3. As she sits there while they're waiting for labs to come back, deciding what else they need to do, her pain kind of goes back up to a 7. And then her family says, I can't take her home like this. Medication works. What are you going to do for her? So they would like the patient to be admitted, and that maybe seems reasonable. Her pain's 7, 8. She's crying. You don't know what to do. So, of course, she's admitted to the hospital service, which is really excited to take her. And we're going to obviously focus on pain control. What are our options? Are we going to do things kind of as needed for this pain? Are we going to do around the clock? Or are we going to use opioids? So and I think everybody here is on the same page. For a patient like this whose ultimate workup proves to be negative, we're really going to want to focus on our non-narcotic analgesics. And we've got acetaminophen, which is a medication we don't really know how it works. And we have NSAIDs, which we know work on the COX pathway. We literally have nothing else. So we get a lot of these consults. You tell us this is what you're doing. We're like, great, we don't have anything else. We go see them. We say, you know, team's doing a great job. This is what we would do. But this is kind of the bread and butter of pain without a diagnosis. So acetaminophen, and I'm just going to review quickly here, dosing for acetaminophen and NSAIDs, because we very often see that these are dosed incorrectly. Acetaminophen is great. We use that first line certainly as an analgesic. We give it mostly PO. Rectal, I want to remind people, this is more of a nursing practice, I think, than a physician practice. These definitely need to be given whole. You can't split suppositories. We had a patient 4 or 5 years ago, came in with a cleft palate repair, left the post-op day 1 or 2, I can't remember, hadn't been giving, I think, rectal Tylenol around the clock. Parents kept giving it when he went home. He came back 4 days later, nearly dead from liver failure. It was really, really eye-opening. We learned that some suppositories had been split while he was in the hospital, so we don't know how much Tylenol he actually got, and he very nearly died. So that, to me, was hugely eye-opening. And so I tend to be a little bit of a OCD kind of person when I'm looking at acetaminophen given to kids. So rectal, we don't seem to use that as much anymore because, again, we're limited to 120 or 325 milligram dose. IV is a great, great, great medication. However, it's still very, very expensive. When you order this, you're limited to a 24-hour run of it, and the patient really needs to be NPO for you to justify using this. We use it in the OR a lot, but it's difficult with our pharmacy manpower. They send us down a 1-gram vial when we really just need 30 milligrams, and then we have to throw that all away because we can't draw it up sterilely and split that. So it's a very expensive drug. It's really great, but I think we're still kind of wrestling with how to balance cost and efficiency here. Guidelines for dosing on acetaminophen vary depending on the source you looked at. Our formulary here actually gave much higher neonatal dosing guidelines than I've seen elsewhere. Most things I have looked at, and we did pretty exhaustive literature search when we had this safety event a few years ago, but a lot of sources suggest limiting dosing to kids that are under 6 months to about 40 mg per kg per day. So a 10 milligram per kilo dose every 6 hours works really nice, and I would stick with that. Pediatric dosing, again, you can go up to about 75 mg per kg per day. From our pain standpoint, we prefer that you give this, if you're using it as an analgesic, around the clock. It takes a while for an oral dose to reach a level, and if you are waiting for pain to appear, then you're calling a nurse, so the nurse has to get it, the nurse has to bring it, and then the patient finally takes it, you can have quite a delay in terms of when a patient actually gets analgesic. So easy way to remember this, 10 mg per kg every 4 hours or 15 mg per kg every 6. Do it around the clock if you're using it for pain. Certainly if you're worried about fever, then you may need to do it PRN, but I've had kids like impressive fevers through it around the clock too. So again, our major side effect with this really is hepatotoxicity. There are several case reports, including one that we did in the literature of kids who have had significant hepatotoxicity for things that you would thought would be in the therapeutic range. So I always very closely look at a kid's Tylenol dosing when we're consulting on a kid, and often recommend tapering it once it's been on for 10 to 14 days. I've seen kids on it much longer than that, but it worries me. As I mentioned before, acetaminophen is a really good drug. It's a good analgesic, but when you give it with a narcotic, you're really limiting the amount of narcotic you can give because you're worried about giving too much acetaminophen, or you're worried about if you're optimizing your acetaminophen dosing, you're giving too much narcotic. Or if you're worried, I don't really want to give them that much oxycodone, you're really shortchanging them the amount of acetaminophen you can give. So we advise not using combination products. Separate them out, give your acetaminophen around the clock, and then if you're giving your narcotic around the clock, stagger it. So the kid's getting something every few hours around the clock. It lets you optimize your dosing on both of those. NSAIDs generally, we use these in kids greater than 6 months, so there's certainly some areas in the world where they'll use it occasionally, sparingly in kids as young as 2 months. We just tend to not do that here. These act peripherally, but they do have some central action. Ibuprofen, you can give a pretty high maximum daily dose, 40 mg per kg, if you're dividing that up, 10 mg per kg every 6 hours. And ketorolac, we like to limit that to about 5 days. So a lot of times we'll see kids then rolled over to a pretty high ibuprofen dose. And I would urge caution with doing that when you're using that much ketorolac, layering a lot of ibuprofen on afterwards as well. Again, our side effects for these, everybody knows these well, and you could consider certainly using some gastric protection if you're using a lot of NSAIDs that they get on, I don't know, whatever's on formulary here, to protect their GI system. We mostly on our surgical services defer to our surgeons in terms of whether or not they'll let us use NSAIDs in the setting of a broken femur or something. But going back to our patient, we really, really urge kids that have non-cancer, non-surgical pain, especially those when they don't have a diagnosis, to try to limit your therapy to non-opioid medications and non-pharmacologic strategies. This kid, I would alternate acetaminophen, ketorolac every 6 hours around the clock, transition to PO. Incorporate certainly child life, distraction things. I'm learning acupuncture. I would go hit her with a few needles. I think it would work really, really well for this kind of scenario, but do other things before you jump to opioids. Narcotics, if the kid's an extremis, you don't know what to do, it's at night, judicious opioids might be reasonable. Use the lowest effective dose that you have and really set the expectation of the family that this is a short-term option as we're trying to figure out what's going on. We're looking at our non-pure opioids, which we, I think, like to start with. Tramadol is one we recommend, and they certainly recommend it too if you look at their website. I was like, wow. It literally was like, you want to order this online? And I was like, nope, no thank you. So, but tramadol is a good option. It's considered a weak opioid. It also works with serotonin and norepinephrine. It does undergo some metabolism, and it needs to be metabolized first to this drug. I don't even know how to say that. I'll leave it there in bold. And that has more effects on the opioid system. The tramadol itself that you're giving has more of an effect on serotonin and norepinephrine, but it's sort of a weak opioid. It may be a good first-line thing to try when you don't want to give a kid something a little stronger. And by the way, this opioid metabolism article there at the bottom is fantastic. It's nicely written. I could understand it, and I'm not like a medical student in pharmacology anymore, but it really lays out opioid by opioid, how they're metabolized and how that may change what you're doing. Tramadol, we typically dose 50 to 100 mg per kg Q6. I don't have a lot of experience dosing it in smaller kids, but we typically do it when kids like 10 to 12-year-old age, when you're not necessarily dosing things on a mg per kg basis. We would use caution when there's a history of seizures. It may unmask that. It shouldn't precipitate seizures in someone who's never had one. And concurrent use of other serotonergic meds, I would kind of urge caution. Though we do have kids who are on SSRIs, and they do use occasional tramadol. I just wouldn't have tramadol be an around-the-clock medication in someone who's already on something that has increased serotonin available. Nubane, we use this a lot. We hear about it used a lot. And the reason people like this in certain scenarios is because it's a mixed opioid agonist-antagonist. So we use it from a pain perspective when we have neuraxial induced pruritus, when we've given narcotics into the CSF or the epidural space, which is really the time that we like to use it. However, we see this used a lot in the inpatient setting with abdominal pain because it has fewer effects on the gut. One thing I would mention about this is that it's not kept on the floor in PICSA stations, and I hear a lot from patients that when this is used as a PRN medication, it takes really, really long time for them to get it because the nurse has to call to pharmacy and actually have it delivered. So this one, if a patient asks for it, it may be an hour before they even get it given when the patient initially asks for it. So this one, well, again, I don't necessarily like to jump to around-the-clock narcotics. You may consider a very low dose of doing this around the clock so that it's available. It's in the PICSA when the patient needs it. I would recommend always using this as a single opioid agent. I wouldn't mix this with other pure opioids, oxycodone, morphine, because it has this antagonistic effect. It'll block the action of the other opioids. I wouldn't put like Dilaudid around the clock, then add Nubane PRN. Conversely, I wouldn't have Nubane around the clock and then, oh, the pain's really, really bad, let's give them something else. They don't work well together and you can precipitate some withdrawal symptoms. So that's that kid. You know how to treat him, right? Yes. Okay. Case number 2, which I want to talk about just because this is a kind of situation where we use a ton of opioids. Kid coming in for posterior spinal fusion, the incision's like a foot long in their back. It's bloody, it's intense, it's a really, really big surgical procedure. This is a 15-year-old guy, let's say. He's on our pain service sort of automatically after his surgery. And this kind of pain we see gets better every day. We reassure the patients, you know, it's very hard post-op day 1, it's going to get better, it's going to get better. And every day they do. They use less and less opioid. This kind of patient, we would give them intrathecal morphine before they've even made incision. We have a low-dose morphine. It works fabulous in the spinal space. And then we would start them on a morphine PCA right away. We would start oxycodone the first day, and then we would give diazepam, PRN, acetaminophen, and ibuprofen around the clock. We expect these kids to need a boatload of narcotics. It's a huge surgery. A lot of times these kids are using 50 to 75 milligrams of morphine in the first 24 hours, next 24 hours. We add oxycodone post-op day 1, but by the time they go home, most of these kids on post-op day 3, they're literally getting oxycodone, Q6 around the clock, a little bit of diazepam, and ibuprofen. By day 7 to 10, they're using very, very little opioid. I think they're sent home with maybe 5 days worth of oxycodone given around the clock, and a lot of them don't even exhaust that. So this is an interesting scenario where these kids have a huge amount of pain, use a huge amount of medication, but they taper very, very quickly. Oxycodone is a medication, if you look at its indication, we talk about it being good for moderate to severe pain. We advocate here for really just using it in its immediate release form. OxyContin is its longer one, lasts for about 12 hours, and we tend to avoid now using it with things like as Percocet, where you also have acetaminophen built in. Again, we don't necessarily want the acetaminophen dose to be limited by your oxycodone, and OxyContin is really kind of rarely reserved for certain things. And certainly if you're ever thinking of using that in a kid, call us and we'll help you sort it out. Oxycodone is metabolized via CYP3A4 and 2D6 to 2 metabolites, but most of the opioid effect is just from oxycodone. Oxymorphone, by the way, it's a very, very strong opioid agonist. It's actually an opioid you can give. It's not on formulary here. It's not used a lot in pediatric practice, but it's just a minor metabolite of oxycodone. For oxycodone, you know, we give it to little tiny babies if they need it. I think there's definitely hesitation in the larger group about using it in tiny infants, obviously. But the way I look at it with kids, if you have a 2-year-old who's had, I don't know, something very, very painful happen to them, and they need something, don't be afraid to use it. You can always cut your dose down. I usually recommend with narcotics, but I'm always preaching to my fellows and residents, is start small. We can always give more. Once you judge a kid's effect from a medication, you can decide where to go with that. You can always incrementally increase your dose or make it every 4 hours. The other 2 drugs I wanted to talk about, the orally used ones, are codeine and hydrocodone, which thankfully is not on our formulary here. Codeine gets a lot of press, or has been recently, because of its metabolism. It's a prodrug. It itself has no analgesic effect, and it has to be metabolized. So if patients rely on a CYP2D6 metabolism to chew this up into morphine. There's a subset of population, the U.S. population is about 8%, that are ultra-rapid metabolizers, so they end up getting way more morphine than you are aiming for. There's also nearly a third of the U.S. population do not metabolize it very well, and they get little to no analgesic effect. So you're looking at a drug that for a third of the kids you're giving it to are not going to get analgesic from it. And then nearly 10% of them are at risk for getting too much analgesia with all its attendant side effects and respiratory depression type issues. This is such a big issue that in 2012, the FDA had received reports and identified 3 kids who had died and 1 that had nearly died after receiving codeine after an OSA, or for OSA after a TNA. These were all little kids. There was some question about if they had been given oxycodone. Would this have been a problem too? But it's hard to say. By 2013, however, FDA put a black box warning on it for its use in kids after a tonsillectomy. And for other pain problems, you really should only use it if the benefits are anticipated to outweigh the risks. We have other medications that I would argue are better and are cleaner and don't rely on this erratic metabolism. The European Medicines Agency and the Canadian Ministry of Health, both sort of kind of our FDA equivalents, actually restrict it to kids that are older than 12. And the WHO removed it from its clinical analgesic ladder for kids in 2012. And they specifically took it. They also don't like to use tramadol because they say we don't have a lot of evidence for its use in kids. However, I know it's hard for me to say, yes, let's follow the WHO because they removed codeine, yet also say we can use tramadol. But I think it just illustrates that codeine is not a good drug for us to be using. Vicodin or hydrocodone, we don't have this on formulary. Some studies that have been looking at replacement with codeine, like what do we do if this has been sort of our routine, sort of mild to moderate pain medication for kids, we're no longer using it. Now what do we do? Some have suggested using hydrocodone, but it also is mostly a prodrug. It is metabolized to hydromorphone or Dilaudid. It probably, I think hydrocodone does have some analgesic effect on its own, but we don't have a lot of data about this. And this medication and codeine in the last 2 years had recently, in the last 2 years have changed their DEA classification to Schedule 2. Previously, these medications were prescribed a lot because it was a lot easier for you to do so. You could fax in a prescription, you could potentially call in a prescription. They did not have the same restrictions on how to prescribe them as our Schedule 2 medications. So this puts it up there with fentanyl, oxycodone, methadone, et cetera. So these are now more difficult to prescribe, both codeine and hydrocodone. And we would kind of argue that they're probably not great drugs. I've never actually prescribed either of them here. I prefer oxycodone for short-term use just because it's a lot more predictable. So that is about all I think I have to say about that. We just watched Forrest Gump, so it's like in my head. No one else seen that? Anyway, so our main pearls here that we would love to kind of instill with you is, again, go for an around-the-clock approach, either with your non-narcotics analgesic stuff, which, again, we don't have a lot of options. Acetaminophen and NSAIDs are it, but they can be good. They're much more effective if you use them around the clock and your patients aren't waiting and waiting and waiting for a nurse to bring them medication. Don't use codeine. Oxycodone will be a nice substitute at this point. Also, stagger your acetaminophen with your opioids. Don't give them at the same time. And definitely call us if you need our help. We are happy to give you some guidance. This is my list of references. And I think Celeste is going to continue on here.
How are you guys doing? Hanging in there. I know it's a lot of information that we're trying to condense in a short period of time, but I'm going to quickly go through because we're running out of time, okay? Okay. So 2 cases that I'm going to present today. Case number 3 is going to be a brief overview of patient-controlled analgesia, or PCA. And then we're going to wrap things up with the prescription opioid overdose epidemic. And I think this serves as the impetus for many states, such as Maryland, actually requiring us to undergo opioid education for medical relicensing, so that we as healthcare practitioners could be cognizant of this epidemic and prevent it from further progressing. Okay, so we're going to get started now. So case 3, we have Sam, who's a 13-year-old male with a history of sickle cell disease, who presents with 10 out of 10 pain of the right lower extremity. It started about 3 days ago after returning from a school trip to the zoo. He took several doses of his prescribed oxycodone and ibuprofen prior to coming to the emergency room. Didn't really seem to help. But he denies any trauma or any recent analysis. He's frequently admitted for pain crisis. His last admission was about a month or so ago. He has experienced pain similar to this in the past when he was admitted for a vaso-occlusive crisis. On physical exam, there's no swelling or deformity to the leg. There is, however, tenderness to palpation of the extremity. In the emergency room, he has received about 3 doses of IV morphine, and his pain is only down to 9 out of 10. It started at 10, it's only down to 9. When you see him, he's extremely cheerful and writhing in pain and refusing any oral intake. He's subsequently admitted to your service for further management of his pain. So typically when a child comes in for a VOC, the typical route of pain management is by giving a PCA. It's also used for opioid delivery in kids older than 6 years old for acute severe pain, and also from those experiencing chronic pain from cancer. It allows for a regulation of opioids in a controlled fashion, so the child can push a button and get medicine delivered. This avoids the delay in receiving medication compared to a PRN dosing that a nurse might administer, because they might be tied up with taking care of other patients and may not necessarily come in a quick and ready fashion to administer medication. And in a sense, this decreases anxiety because the child knows that they can give medication to themselves and not have to wait in pain for medication to come. And ultimately, this results in patient satisfaction. And it's important to note that a PCA does not necessarily decrease the overall opioid use. In most cases, it actually increases opioid use. Okay. So at our institution, only the pain medicine service can initiate and make modifications to a PCA, the only exception being the hematology service, which can start a morphine PCA in a patient who's admitted for VOC. And you first want to make sure that you assess a child for the ability to actually use a PCA effectively. So one of the things we look for is, can they push a button? And one of the things that we look at is see if they can play a video game at home. If we know they can play a video game, I mean, not just tapping around on an iPad, but actually playing a video game and maybe winning, we know that they may have the cognitive ability to actually use the PCA effectively. So at our institution, we've used age 6 to 7 as a cutoff because we feel that the kids have the cognitive ability to use the PCA appropriately, knowing that they're in pain. If they push the button, they'll get medication, and as a result, be comfortable. So you also want to assess the level of pain. If pain is mildly controlled, the PCA may not be necessarily advantageous in that setting. You want to look at the type and quantity of medication attempted prior to requesting a PCA. It's not uncommon that we get consults in our service for a kid who's getting a suboptimal dose of morphine and they required maybe 5 or 8 doses of that and they're asking a PCA. But then when we actually look at the quantity of medication, you tell them that they can further be optimized and maybe a PCA is not really necessary in this setting. So when we started dosing, we actually use the patient weight as a guideline to start the dosing of a PCA. And it's important to individualize the PCA parameters based on the child's medical issues and or history of PCA use if it's available. So for example, if you know that a child might be sensitive to opioids or they may have obstructive sleep apnea, their opioid requirement may be less, so their starting dose might actually be less than the recommended starting dose. And conversely, if you know a patient's opioid tolerant, their starting dose might actually be somewhat greater than the recommended starting dose. You also want to ensure that you educate the child and the parent regarding the use, because parents might be available at that side and be a helpful reminder to push the button, but at the same token, you don't want the patient's parent to actually be pushing the button because that can lead to situations of over-sedation. So we typically use 2 opioids for the PCA. Morphine is the most commonly used agent, followed by Dilaudid for those who might be intolerant to the side effects of morphine. And the agent selection should be based on the efficacy of the task use if that information is available and the ability to tolerate the side effects. So morphine is a synthetic opioid agonist. It's a standard opioid to which all others are compared to. It's metabolized by the liver to 2 substances, morphine 3-glucuronide and morphine 6-glucuronide. The metabolites are then excreted by the kidney, and in cases where there's impaired renal function, those metabolites can actually accumulate and cause side effects of their own. So morphine 3-glucuronide is inactive and it doesn't have any analgesic properties, but in the settings of renal failure, it can accumulate and cause agitation, even seizures and delirium. Morphine 6 is an active metabolite with analgesic properties somewhat similar to the parent compound morphine, and can cause drowsiness, nausea, vomiting, and respiratory depression. Side effects of morphine include sedation, respiratory depression, nausea, vomiting, constipation, itching, and urinary retention. It can also be associated with a histamine release, and you can notice urticaria or a wheal appearance over the vein through which morphine is administered. And in rare instances, it can actually cause systemic hypotension. Hydromorphone or Dilaudid is another synthetic opioid agonist. It's more potent than morphine by a factor of 5 to 8. It also is metabolized by the liver. It's metabolized inactive and is often the choice in renal failure settings. The inactive metabolite can actually accumulate, leading to neuroexcitation and cognitive impairment. And we've actually only seen this about once in our setting when we've been consulted for a PCA. No, hydromorphone shares a similar side effects as morphine, but they're somewhat less so compared to morphine. So when we dose the PCA, we select the demand dose, and that's the dose that's delivered with each push of the button. You can see that the dosing parameters are somewhat different for morphine and Dilaudid. We also select the lockout interval, and that's the time from when they first push the button to when they can actually push the button a second time and actually get medications delivered. We can also choose the continuous if we choose to do so for a given patient. So we're often faced with a question when we start a PCA, do we include a basal infusion or not? So this lists some of the instances where you would want to start a continuous infusion for the PCA. So in situations where you have chronic opioid use, high severity of pain, chronic illnesses such as sickle cell disease and cancer, where you know the patient is more likely opioid tolerant, and any extremely painful procedures, because you're anticipating that they'll probably need a higher dose of pain medications than what's standard. Okay. Reasons not to include a basal infusion, or at least to consider a reduced starting dose, would be those who are opioid naive, those with mild severity of pain, mildly painful procedures, and if you have a history of respiratory problems, as I mentioned before, obstructive sleep apnea, because they might be more sensitive to opioids. In some settings where they might be sensitive and they may risk hypoventilating and require urgent intubation. If you know a kid has a history of a difficult airway, difficult intubation, you may want to refrain from using a higher dose for your infusion. And also if they have a prior episode of sedation, hypoventilation with opioid use. Okay, so this picture and the next two on the follow, I think is a really good depiction of PCA use. So achieving an adequate state of analgesia is often a compromise between two extreme states, hypoventilation and pain. So you see that listed here on the y-axis. On the x-axis, you have a given interval of time, and the actual tracing represents plasma opioid levels, okay? So in this patient, they have a PCA with a demand and basal infusion. So our patient here is starting with somewhat mild pain. They push the button once, and then they get back into that zone where there's adequate analgesia. So then they fall asleep, their opioid levels begin to drip down a little bit, and then their pain starts to increase. They push the button once again, and then they're back in that adequate state of analgesia, okay? The next picture shows a demand-only PCA. So same X and Y axes. We have a patient starting out with adequate analgesia. They fall asleep, their opioid levels begin to drift down, and it takes several pushes of the button before they can get back to a state of adequate analgesia. And then last, we have a patient who has a demand and a continuous PCA, but the continuous might be a little bit high, or maybe they could just be simply sensitive to opioids. So they're starting out in a range where they have appropriate analgesia. They decide to push the button again, and then they get into that dangerous zone of hypoventilation. So then they fall asleep, and despite not pushing the button, the levels begin to drift up and up again until they get back to that unsafe zone of hypoventilation. So that's why it's important when kids are on a PCA, they have adequate monitoring, such as oxygen saturations, pulse ox monitored to ensure safety. So when we're transitioning off a PCA, we use clinical improvement as a cue to start the process. So if sometimes the kids can actually start weaning themselves off of a PCA and that would be indicated by decreased use over time. So we typically stop the basal rate and would start an oral opioid such as oxycodone. And if the pain remains well controlled with the new regimen, the PCA can be ultimately discontinued. So our friend Sam with vaso-occlusive crisis. So our step would be to first review his past admissions. They determine which medication has been successful. Did he require escalation of opioids? Did he experience any side effects from the chosen agent? and then we would start a PCM, most likely a demand and continuous infusion, and then ultimately notify the pain medicine team so we can follow him. Okay? So then we move on to case number 4. We have Charles. He's a patient who recently injured his back after sustaining a fall. He tried some of his mother's OxyContin pills and found that he experienced considerable relief, so much so that he now comes to your office asking for a prescription of his own. So how can his risk for overdosing on prescription opioids be minimized? So much of the statistics and diagrams that I'll show you are actually from the CDC. So prescription opioid overdose is a true epidemic, and prior to preparing for this, I didn't know how severe this was. So in the past decade, the amount of prescription painkillers prescribed and sold in U.S. increased by a factor of 4. And this is despite the type of pain, the quality of pain that Americans have been reporting are essentially unchanged. So in the United States, about 44 people die per day from opioid overdose. In that last decade, the majority were between age 25 to 55 years old. The majority were non-Hispanic whites. Although men are more likely to die from prescription opioid overdose, the gap between men and women is closing. In that past decade, deaths from prescription opioid overdose among women increased more than 400% and over 230% among men. Drug overdose was the leading cause of injury death in 2013, and among people 25 to 64 years old, drug overdose caused more deaths than MDAs. There were over 22,000 prescription drug overdose deaths in the United States in 2013. 70% involved opioids, and about 30% involved benzodiazepines such as Ativan. Okay? And on autopsy, people who died of drug overdoses often had a combination of both opioids and benzodiazepines in their system. So the upsurge is due partly to providers such as us overprescribing pain medications for chronic non-cancer pain. We never want to leave any of our patients in pain, but along with our friends from JCO now looking at our pain scores, I think it's led to the impetus to try to prescribe medication sometimes when it's not really necessarily indicated, as Dr. Reece mentioned earlier. And then some people feel leaving patient in pain is unethical. And actually, there's very little evidence to support that chronic opioid use improves the quality of life or functional status. And overdose rates are actually higher in states that overprescribe opioids. So I think this is a really nice illustration that wraps things up. On the x-axis, you have interval of time in year, starting from 1999 to 2013. And this is kind of similar to what Dr. Reece showed you earlier. So the orange tracing here represents sales of prescription drugs from 1999 to 2013. And in orange, you actually see the number of deaths from the same time period. And you can see there's somewhat of a direct relationship between sales and deaths. And it isn't around until 2010 where you start to see things leveling off a little bit. So the cost of opioid overdose is pricey, right? So not only are you losing a loved one, but it also places a financial burden on society. In the United States, prescription opioid abuse costs were about $55 billion in 2007. The majority were due to lost productivity in the workplace, and also the price to pay for the abuse treatment, and also from criminal justice costs. So this little diagram is also from the CDC. It shows that there's variability in the prescribing among states. So the darker colored regions are an indication of states that actually have high prescribing rates. DC is located right here. It's in the light hashtag purple, and so they're among the highest in terms of prescribing. Maryland and Virginia are also in the orange section, so this DMV region likes to prescribe these pain medications. Okay, so what is the cause of this large variability? The medical issues that cause people to seek out pain medications do not necessarily vary from state to state. So that's not the only reason to explain why there's such a great variability. Other factors that may influence prescribing rates include healthcare providers in different parts of the country do not have a general consensus on when to prescribe opioids and how much to prescribe. Some of the increased demand for prescribing these opioids are from people who use them non-medically. They've used them for the thrill of it, for the seek and the high from these medications. And some of them choose to sell them and obtain them from multiple prescribers. There are actually unethical pain clinics in many states that seek their own financial gains by prescribing pain medications to people who don't need them medically. I'm sure you've heard in the news at least once a year some physician who's earning $1 million a year, and you find out that they're going off with cuffs to jail because of overprescribing these medications unethically. So the pediatric population itself is not immune from this epidemic. Opioid abuse in adults have an adverse effect on the children. The adult opioid use is linked to an increased probability for child abuse. Opioids in the home increases the risk for accidental pediatric ingestion, and from the time period 2001 to 2008, children in the U.S. under the age of 5 had a substantial increase in emergency room visits because of accidental ingestion of opioids. In 2013, more than 6% of children from the age 12 to 17 had engaged in non-medical opioid use, again, for abusing it and just the thrill that they get from it. And some of the kids actually feel it's somewhat more acceptable to abuse prescription painkillers because it's prescribed by a doctor, and feel it's somewhat better than, let's say, abusing marijuana. So they think it's okay. So many teenagers prefer borrowing medication to seeing a healthcare provider for opioid prescriptions, either take it from friends or from family members. So who is at risk for overdose? Those with chronic medical illnesses, receiving medications from multiple providers and pharmacies, and obviously consuming a high dose of prescription opioids on a daily basis. And importantly, receiving long-acting or extended-release opioids such as OxyContin for acute pain situations. If you had a history of previous overdose, you're at risk as well. And if you had a period of abstinence where you went to detox and then you come out and you fall off the wagon and start using drugs again, your tolerance can change, and then you're more likely at risk for overdosing. And then mixing substances such as other benzodiazepines, alcohol, or other illicit drugs increases your risk for overdose. So over the course of time, roughly around 2010, when we started magically seeing the deaths tapering off, there's been many initiatives on the state and federal level to try to curb overdose. So one of the ones that's pretty prominent in most states is the Prescription Drug Monitoring Program. Their state-run electronic databases that track and monitor controlled drug prescriptions and dispensing. It's designed to stop patients from obtaining multiple prescriptions from multiple doctors from multiple pharmacies. And every single state, including the District of Columbia, has this in place. The only exception is Missouri. So these states, they can look and see who's getting prescriptions from which pharmacies, but they cannot necessarily look and see what, let's say you're in Maryland, you can't look and see what's happening in Virginia to know if a patient is crossing state lines to actually obtain these medicines. So that was up until, I think, 2011, 2013, when they developed the PMP Interconnect. And that's another database that actually facilitates the transfer of the data across state lines. It allows participating states to be linked to provide a more effective means of combating drug abuse across the country. And this is a list of the participating states. You can see Maryland and Virginia are listed there. And the states that are not listed are actually in various stages of being members of this program, the exception being Missouri because they don't even have their own state program. Other initiative is the trying to get drug disposal of these medications in a safe and effective manner. Physicians themselves cannot collect and leftover medications and dispose of them. It's not recommended that they dispose of medications in trash or even flush them down the toilet because it can ultimately return to our drinking water system. Instead, the remainder should be sealed in a bag with inedible substances such as kitty litter and coffee grounds and then disposed of. So there are national programs such as the Prescription Drug Take Back Day. The next one is actually this upcoming Saturday. It's sponsored by the DEA that allows patients to return their controlled substance in an environmentally friendly manner. And it's free of charge, anonymous. No one's going to ask you where you got the drugs from or what are you doing with it. And healthcare providers are encouraged to advise patients about these services. And last but not least, safe opioid prescribing education, much like the one that you're here for today. It's necessary for medical relicensing in many states, okay? And in the event that there is a drug overdose, naloxone is somewhat of a therapy for that if it's caught early. It reverses the respiratory depression and sedation. It's an opioid antagonist that competitively binds to opioid receptors. It has a duration of action about 1 to 4 hours. But if you're using or trying to reverse a long-acting opioid such as OxyContin, more than one dose of it might be required to reverse the effects. Some of the side effects of naloxone itself is, since it's actually competing with opioids, it can actually result in increased pain. And naloxone is also noted to have a increase of catecholamine release. So it's not advisable to give it in a quick fashion because it could result in hypertension, arrhythmias, or pulmonary edema. So how can you help curb this epidemic? What can you do? So ultimately, you want to make sure your patient has adequate analgesia, but you want to provide a safe, effective pain management program while reducing the risk for overdose. This includes educating the patients about the risk of taking prescription opioids, such as overdose and death, and certainly not using other prescriptions that are not necessarily prescribed to the patient, and using non-opioids such as Tylenol, NSAIDs, physical therapy, and exercise. You want to ensure responsible opioid prescribing. You want to prescribe the lowest effective dose and only the amount that tells the need for the anticipated duration of pain. You want to instruct your patients how to stop their opioids and when the treatment is done. You want to provide your patients with information on how to use, store, and dispose of their opioids. And also avoiding combination of prescription opioids and sedatives unless there's a specific medical reason that they should be given together. And also using your state's prescription drug monitoring program to identify patients who might be at risk for overdose. So our patient Charles, who's coming in for OxyContin for new onset back pain, we're going to tell him no, obviously. Educate him about the dangers of opioid use. Encourage non-opioid pharmacology such as ibuprofen and Tylenol, and encouraging physical therapy. All right. Okay, made it.
All right, thank you very much.
I know we're over time, but...
No, we're in good shape. Thank you, Dr. Martin. Thank you, Dr. Reece, for this instructional session. Thanks for the medical education department for helping to help facilitate it. And I think we have a minute or two for questions if you guys want. And so if anybody has any questions, please ask. Yes.
How are you handling the request we seem to get all the time by teenagers of I'm insane and marijuana is legal and you're a doctor?
Well,
we have a policy in the hospital. We're getting out of that.
I don't believe we have a policy on that. Sean, do you want to?
Hi. Currently, we do not have a hospital-wide policy. And as for, we don't have activating women's health right now that can prescribe as of yet. So that is something that needs to be looked at, or at least from the pain team.
I haven't done it yet. That prescribers have to, like any legitimate prescriber in the hospital has to apply. Right, and then you can prescribe, which I haven't done yet. But surprisingly we do get asked from a palliative care standpoint occasionally, but I think the hardest thing we've had to do is for patients who legitimately could use it. We can't do it for anyone outside of DC, unfortunately. So but I haven't done that.
We've had a fair... Oh, no, it's fine. I'm loud enough. We've had a fair share in the pain clinic right now, so we're looking at having one or two providers go through the licensing process. But then, from a hospital-wide standpoint, we've yet to look at sort of the ethical prescribing standpoint of how do we sort of put that out there and say, we do have this as an option. We keep it thinking of the palliative care. That's well through the discussion right now.
One more question. Yes, please.
I have patients who call me, like, kind of that patient went home and in this hospital or something like that. Sometimes those that.
I'm sorry, what do you mean they missed?
When the patient goes home with a child and they miss the prescription for pain medication, and then they call the OR, I don't have the prescriptions of these hospital handles at pain clinic or the doctor.
I think usually the prescribing doctor, because if you're talking about the acute post-op situation when they're sent home from the PACU, typically the surgeon's team is the one who writes those prescriptions. So then you would have to get someone from their team to either try to get them a script, or if the pain is that excruciating, then they would have to come back to at least the emergency room to get their pain under control. Well, if their pain is that bad, then they can't tolerate it. Yeah. Yeah, but it would be the surgeon.
All right, please help me thank Dr. Martin and Reece again.